So my name is Brittany Watson, and I work as a practice consultant in professional practice. And the purpose of today's session, obviously, is to do a little bit of an introduction on informatics. And my portfolio within professional practice is clinical informatics, so it's somewhat fitting to be here. So as a bit of an icebreaker before we begin, I have put up this screen and with the question that says, can you guess the meaning of these words? Was anyone able to guess the meaning of any of these words? Julia. What did Wayne say?
The last one's technology.
The last one is technology. Yes, you are right. That's super. So if you're thinking that you're going to learn Dutch, then you're kind of in the wrong session. But I put this up for a very distinct reason. And the reason being is that when we talk about informatics, it's kind of been this buzzword over the last little while. And we've heard, okay, electronic health record informatics. What actually is this? So I thought it might be helpful if we're able to relate informatics to something that we are familiar with. So essentially, when we talk about learning about informatics, we're essentially asking you to learn a new language. So if you're interested, these are actually what the words actually do stand for. But as I started doing a little bit of research then about what does it mean when we're learning a new language and what are some principles about second language acquisition, I thought that they might be helpful to explain just because they provide some reference and a reference point for as we go through this session as to what we're actually trying to do. So one of the first principles when it comes to learning a second language is that we want to provide opportunity for the language and the terminology that we're using to be, we want to present the words frequently so that people are able to actually learn the words. So the more often that we present them, the more often we hear them, the more likely we are to retain them. The second principle when we think about learning a second language is that we want to present foreign words in a context that we are familiar with. So for example, if I was to go to France, it'd be much easier to learn French in my current setting where I understand English, as opposed to going to France and then having to learn French there. So same when it comes to informatics. We are wanting to teach about informatics now within a context that we're familiar with. So for example, our SCM system, so that when we do get a new information system, we'll be able to leverage the learning that we've done currently. And then the third principle to keep in mind is that learners require time to understand the words, and we want them to learn at their own pace. So instead of us having to force people to learn informatics at the time when we implement a new information system and an electronic health record, we want to provide opportunity now to go about that learning so that we can maximize that potential when we do have our new system. So just some things to keep in mind as we move forward. So we are here for basic informatics for leaders. And I do, just before we begin, just want to acknowledge Chris Toulousan. I know most of you are familiar with him, and he has come to your programs and he's done a little bit of teaching with the nurses, but he's been a great help to me. So thank you, Chris, for all of your support. So if you were at ELF during July, Shelley Fraser and I presented on the education strategy for informatics here at Providence. And basically, all that I want to summarize for this presentation is that this is the first education series within, or the first education session within a series that will happen for leaders with regards to informatics at Providence. So stay tuned for further sessions as we move forward. So the objectives primarily of today are that we want to provide awareness to how we're currently using informatics in practice. Then we want to just provide some opportunity to appreciate what are some informatics concepts and terminology that we should be aware of. And then lastly, we'll go into a little bit of computer literacy and what is our role in preparing ourselves and our leaders for that. So when you walked in, hopefully you picked up a sheet of paper that has informatics related questions on it. The purpose of that sheet of paper is to provide a little bit of structure for yourselves when it comes to learning. And all of these 5 questions will be answered in the presentation today. And basically, they're there for yourself. I'm not going to be looking at it. I'm not marking it. It's for your own learning, and it's basically a tool for self-reflection. So at the end of today, you're able to recognize maybe where there's opportunity for you to continue to do some of your own learning. Hopefully, at the end of this session, if someone was to ask you, like, what's an electronic health record, you'd be able to say, well, this is what Brittany told me. And if not, well, then maybe you and I can meet next week. But that being said, it's for yourself. So hopefully it does help with the session. So I thought it might be helpful before we get into some of the content to provide a little bit of background as to why all of a sudden informatics is this hot topic. Why are we talking about it? How come there's so much emphasis on it? Why are we speaking about Cerner and CST? How did that all come to be? So I think if we can all appreciate our desire for healthcare as practitioners is that we want to be able to provide healthcare that's collaborative, patient-centered, that's based on evidence, and that maximizes on access for patients. However, we also recognize the fact that we work within healthcare and it's complex. It's challenging to get access for patients. Often information for patients lives in multiple locations. Sometimes we duplicate tests for patients. And sometimes it's hard to keep up our standards, keep them up to date. So what we have here is Canada Health Infoway. So Canada Health Infoway is a nonprofit organization that is funded by the federal government. And they have been tasked with the responsibility of supporting each province across Canada in moving towards this vision of collaborative, patient-centered, and evidence-based healthcare delivery. And their method of doing that is through the implementation of an electronic health record. So this electronic health record is not something that's solely happening within British Columbia, but it's a project that has taken place across Canada. So Ontario, for example, has already implemented many electronic health records, and in BC, we are beginning that work here. But this is not something that we can say is only within our province, but something that is happening across the country. So what is an electronic health record? When we hear that word, what do we think of? Essentially, an electronic health record you can think of as a complete record of a patient's health care over the course of their lifetime. So what that means is that an electronic health record, it talks to other services. It doesn't just stay within the hospital. So it talks to pharmacies, it talks to labs. It is a complete record of all the care that the patient has received over the course of their lifetime. But you might have also heard terms such as electronic medical record and a personal health record. So how do we distinguish between all of these terms? So the two primary ways to distinguish are to look at the custodianship of the record and to look at the completeness of the record. So an electronic medical record, the custodian of that record is the healthcare team. However, these records primarily live within one office. So we consider them to be a partial record of a patient's healthcare that they've received over the course of their lifetime. So what that means is that here in Vancouver, for example, we have many electronic medical records that live within a physician's, like a family physician's office. But those records do not talk to any other service outside of that family physician office. Whereas a personal health record can be either a complete record or it can be a partial record of a patient's health care over the course of their lifetime. And the custodian of that record is the patient themselves. So that's why it could be a partial or a complete record, because it's dependent on the patient for them to update the record accordingly. So here within our CST project, we're implementing an electronic health record. So that record should be a complete record over the course of the patient's life, and it will allow multiple services to document and have access to it. So I thought it might be helpful, as we're talking about this electronic health record, to get a better sense of what people are saying about it and what are some of the advantages of it if we look at what clinicians across Canada, their perspective on this electronic health record. So the video is quite short, it's only 2 minutes, and then we'll continue on with the presentation.
Information is power, and information allows you to appropriately manage the patient.
Access to information is key in terms of making good decisions for patients.
Lorsqu'on a accès de façon instantanée à ces informations-là, on peut accélérer les prises de décision.
They'll go at 9 o'clock in the morning, they'll have their blood drawn. By 10 o'clock, the result will be on my screen. So that's a huge improvement.
It's a portable, accurate record that many different healthcare providers can access.
All the blanks get filled in and all the gaps are covered because we're able to see what other healthcare workers are doing as well.
It really sort of helps paint sort of a bigger picture.
And everything being all together in that one chart, the duplication that will be decreased will be enormous.
It definitely has streamlined communication amongst primary healthcare providers. That's been a really critical link for us.
It's going to change workflows in a clinic. It can give opportunity for electronic scheduling. It can give an opportunity for quick decision making. It can save extra appointments.
The faster things are in motion, the quicker you can actually give the patient the right treatments.
In fact, the opportunity for us to actually use that record to dialogue with the patient is fantastic.
As well as empowering clients to be able to take on some of their own healthcare.
So now we have email, now we have text messaging, now we have video text messaging. It's just the way of the future, and if we don't do it, the younger generation are going to look at us and say, these folks didn't do anything for us.
C'est qu'aujourd'hui, on est dans une ère de globalisation et d'internationalisation. Et puis c'est important de pouvoir communiquer entre nous.
We really have a truly comprehensive system that is in the interest of the best quality care and experience for patients in this country.
And that whole picture of the patient provides the best possible care.
Okay, so I think one of the key messages that comes through from that video is that with the implementation of an electronic health record, we truly have an opportunity to transform practice. This is more than just a technology project, but we have the opportunity to make changes to the way that healthcare is delivered and ultimately, through that, hopefully to improve patient outcomes. So, Canada Health Infoway, they decided to do a research project across Canada. And one of the key factors that they were looking at in this research project was to try and understand what are the key enablers or the key drivers that lead to a successful change project that includes technology. And when they were looking at this research, when they looked at the data that they were able to discover, what they found out was that engaged and visible leadership was the primary enabler of a successful change project that involved technology. And I say that because I think that's important to recognize, but then when we look back at our organization, we also can appreciate the fact that we have many intelligent and bright leaders here. But most of us went to school and finished off our schooling at a time when informatics was not a part of our education curriculums. So we're asking people to perform and to succeed within an area of practice that they might not have any formal training within. And I think that another statistic that further emphasizes this is that if we look at the west coast of North America, there are 36 schools that offer some form of a master's degree in nursing. 13 of those schools have a requirement for an informatics course. And that's in current state today. So that's not even half of our current schools are providing the opportunity for our clinicians, our leaders, to be trained within informatics. So with that in mind, we know that here at the Health Authority, we have an opportunity and a responsibility to educate our leaders within informatics and to give them the opportunity to become acquainted with this area of practice. So that's part of the reason why we're here engaging you. So what I'd like you to do is, with the people just around you, just take a few minutes and discuss. When you hear the word health informatics, what does that mean to you? What do you think of? Well, if I was to tell you in the most simplest terms what health informatics is, I would tell you that health informatics is concerned with information flow and communication within practice, education, and research to support patient outcomes, decision-making, and workflow. So essentially what we're doing is we're looking at how data is transferred from one place to another and how we can use that data to help make decisions and to make decisions that are going to improve patient care. So what about IT? Because we often hear, well, isn't informatics the same as information technology? How do they differ? So when we talk about information technology or IT, we are essentially referring to the hardware and the software that we use. So when I say hardware, what I mean is the computers, the laptops, our cell phones, the tablets, that's all considered hardware. The software would be all of the applications that we load onto the hardware. So for example, Microsoft Office, Windows 7, our current system of SCM, those are all applications, software applications that are loaded onto our hardware. So essentially though, IT and informatics, as much as they are separate, they do work together in the sense that informatics helps IT work well, and it helps it work effectively. So what do I mean by that? Well, if we're to look at this example here, this top screenshot, as many of you would be familiar with, is a screenshot of our lab results within SCM. And if you look at the yellow line there, that yellow line is highlighting the sodium values for a patient. So in order for us to recognize whether or not the patient's sodium values are trending downwards or trending upwards, and whether we need to make a decision to call the physician for further intervention, we have to look at every data point and then compare them to understand whether or not the value is getting higher or lower from the normal. So that can take time. An informatician would come and they would look at this and they would produce a graph that looks like the bottom graph. And as we can see, if we were to look at that bottom graph, very quickly we can make a decision and recognize that that patient's sodium level is trending downwards, and that we're comfortable with the fact that it is going towards the lower end, towards the baseline, and therefore at this point we don't need to make a decision to contact the physician. So if we go back to our definition of informatics, that's looking at communication to help improve decision making, we can see here that the way that this data is being communicated in the bottom graph does support our decision making, because we're able to make a decision much more quickly. So with that in mind, once again, just with the people around you, I'd like you to take a few minutes and discuss what are some examples of informatics that you use in your current daily work life or just your daily life outside of work. What are some things that you can think of? So take a few minutes and then we'll come back. Okay, so do we have some examples that people are willing to share?
Online banking.
Online banking, absolutely. Yes. Julia?
I'm just saying that My Health.
The My Health, yeah.
It shows a trend in care.
Absolutely, yeah, for sure. Right, so yeah, for sure. Any other examples? Google? Yeah. Cell phone, yes. Texting. Yeah, those are all good examples. Great. So just a few examples that I have here. So cell phones are one example of how we're using informatics in current practice. So as many of you would be aware, the more that you text or that you write emails on your cell phone, the more that your cell phone then begins to recognize the words that you use. So for example, I know that now when I start to type the first 3 letters of my name, or the first 4 letters sometimes, B-R-I-T, my cell phone will automatically populate with T-A-N-Y. So I don't need to type those letters, I just need to press enter, and then my name will be populated in the email that I am writing. Further to that, another example here is just sometimes when we start to write the prefix of a word or the first part of a word, then the cell phone, our BlackBerries will populate with different endings that we can choose from. And that's all related to informatics. So once again, it's helping our workflow because it's making our typing of an email more efficient and more accurate. Another example that we have here within our Sunrise clinical system is auto-paging. So auto-paging is an example of informatics because we know that when we input an order for an OT referral or a PT referral, we put this order into SCM, we click submit, and then there's no further action that we need to take in order for that message to end in the hands of the occupational therapist or the physiotherapist. After we click submit in SCM, we don't have to pick up the phone and dial a number. We don't have to submit further information. We can rely upon the system to inform that healthcare provider that we need them to come and see the patient. So once again, auto-paging is a way of helping with our workflow. And last but not least is our workload measurement tool. So this workload measurement tool, as many of you would be familiar with on the clinical wards, this can be used at times to help give a numerical value for the workload of an individual practitioner. And these workload measurement tools, the values that are produced can then be used for decision making when it comes to staffing and when it comes to the care model that's chosen within that unit. So once again, this is an example of how data can be used to help with decision making. So if we're already using informatics in current day practice, then what's going to be so different with the implementation of an electronic health record? And I know that this fruit tree might look a little bit silly, but I think that it is one of the easiest analogies in hopes of understanding what will be different with the implementation of an electronic health record. So if I was to ask you to go and to pick fruit from this tree, most of us would likely go to the tree and we would pick the fruit that we had the most readily available access to. And that would likely be the lowest hanging fruit. One, we can go and we can easily access it. It doesn't require a whole lot of additional strategy. And we're able to receive the outcome that we had hoped for. We're able to achieve receive the fruit that we had set out to get. But once all of that lower level fruit is gone, then in order to get to the next level and to get the fruit that's at a higher part of the tree, we're going to need additional strategy. So whether that be we're going to have to learn how to climb or we'd have to have a ladder with us, we're going to require something in addition in order to access that fruit that we cannot currently reach or that we might not even know even exists at this time. And that electronic health record is like that additional strategy. It will allow us to access data that one, we currently do not have access to, or two, that we currently don't even know exists. So if we think of a clinical example, about 15 years ago, one of the key measurements that we were looking at in order to predict somebody's outcomes after they had a myocardial infarction or a heart attack was we were very curious to know their door to balloon time, so otherwise known as the time at which they were diagnosed with a heart attack, and then the time that they got to the catheter lab in order to have a stent put in to relieve the blockage. So we use data in many different ways in order to improve that process. And our door to balloon times when we first started off were at about 4 hours, which have now decreased to about 90 minutes, which is an acceptable measure. But in order for us now to further improve that process of maximizing somebody's outcomes after a heart attack, we need to look at different data. We need access to different data to better understand what other parts of this process can we improve upon to further support the patient. And with an electronic health record, we'll have access to that other kind of data that we currently don't have access to. So, Are we doing okay? Yes? Okay. So just before I go into the next subject, I just want to summarize quickly. So we've talked a little bit about Canada Health Infoway and what their vision is with the implementation of an electronic health record. We've talked about what is an electronic health record, the difference between informatics and information technology, and then some examples of informatics in current practice. So the next thing that I'd like to speak about is just some of the competencies that we are going to look at when we're working within an electronic health record. And I think it's key to note that these competencies are not competencies that we're saying that we are asking you to become an expert within informatics, but it's more or less just what are some of the key things that you need to be aware of when it comes to informatics. And when we look at a global level, it's challenging to look at what are the universal competencies that these informatics associations are telling us that leaders require, because they vary from association to association. So these competencies are coming from COACH, which is the Canadian Association for Informatics. So the first competency that we're going to look at is information management, which includes both understanding and interpreting healthcare data. So before we can actually look at what is data, I think it's important if we just understand what the definitions and the differences are between data, information, and knowledge, because these terms often are used interchangeably. So if we look at data first, data in and of itself is facts that have not had any analysis. So basically facts for which there is no context. So for example, if I was to give you this number is a piece of data because if I don't tell you anything about it, all that you know is that it is a number. There's nothing to reference it. But if we look at information is data that has been analyzed, so data that has some context to it. So if I tell you that this is my phone number, now that data is no longer just a piece of data, but now it is information because I'm giving you context to what that number actually refers to. And then knowledge is the combination of data and information that helps us make decisions. So for example, the knowledge that can come from this example is if somebody calls this number, they're going to know that they're calling me. So I think that helps kind of break down what's the difference between data, information, and then how data and information build towards knowledge. So if you were at ELF back in July, this activity might be familiar to you. But I'd like you, with the people just next to you, to describe what you see on this on the screen. So take a few minutes and describe what do you see on the screen. Okay, so I think it's fair to say that if we were to try and compare all of our descriptions of what we saw on the screen, it's unlikely that this entire group used the exact same words to describe what is on the picture. And when we use different words to describe something, we're at the risk of misinterpretation because we often are all using a different way, different vocabulary to go about explaining something. And in the midst of that, there's possibilities that because we're using different words and different vocabulary, we're explaining something differently. There's opportunities for people to misinterpret us. And we often spend more time trying to explain what we saw as opposed to actually using the information to make a decision. So when we're building an electronic health record, one of the solutions that we can build into this record is something that's called a standardized terminology. And essentially, a standardized terminology is like a common language. And what it allows for is a shared understanding to be transferred across a continuum of care. So what I mean by that is that if we refer back to that example of the cake, the overall concept that we had there was a dessert. But within a standardized terminology, all of the synonyms that would align with a dessert are built into our record underneath the concept so that they're all coded the exact same. So all of the words would share the same numerical code. So that means that I could describe that picture using one set of vocabulary. Chris could describe that picture using a different set of vocabulary, but the system would know that because of the words and the synonyms that we're using, essentially we are both describing a dessert. So that is important because what it allows for is that it allows for information to be shared in a more powerful way, and it also allows for improved clarity and accessibility to the data. So when we look at data, it's important to understand data, but then it's also important that we analyze the data within the context that it is being presented to us. So if we look at these two graphs up here, the red bars are representative of a national average, and the blue bars are representative of an average within a community of care. And the first graph that we have there says hospitalized acute myocardial infarction event rate. And this graph shows us that within this community of care, our population is healthier than the national average. There are fewer people that are having heart attacks. But if we look at the next graph there, it says 30-day acute myocardial infarction in hospital mortality rate. And there, within this community of care, it's showing us that even though within the community we have a lower rate of heart attacks, when it comes to the hospital setting, more patients are dying in hospital who have had heart attacks than the national average. So it would be easy when looking at these two graphs to think, well, maybe there is a mistake or that doesn't really make sense. But that's where when I say we need to analyze the data within the context that it's presented to us, that's where we have to be careful. Because the first graph is showing us a community average, whereas the second graph is referring more to a process measurement. So that's within the hospital. So they are showing two different pieces of information. So that's why it's important to understand the context in which the data is being presented, even though they both are showing statistics on myocardial infarctions. Okay, and the last competency that I would like to speak about today is computer literacy. So as many of you are aware, Chris came around and he just talked with some of the nurse educators and some of the staff about where do you think your staff are when it comes to computer literacy? How familiar do you think they are with a computer? And we were able to take some of that data, and I'll present some of those findings a little bit later. But basically, when we're talking about computer literacy, what we're looking at is we want to know that our staff are comfortable using a computer, but further to that they're comfortable troubleshooting a computer, so that if they are to encounter an issue, they understand how they can go about fixing it. So why is this important? Well, it's important for user readiness when it comes to implementation of an electronic health record, because as we currently know, we work within a system where we can have staff that necessarily don't have to know how to use a computer. But when it comes to an electronic health record, there's no workarounds. Everybody will have to be familiar with a computer and how it works. And further to that, we know that computer literacy does support a successful implementation, even though it doesn't guarantee proficiency within an electronic health record, but it does help with supporting a successful implementation of an electronic health record. So one of the interesting pieces of information, just to give a little bit of context as to maybe where we can invest some energy and some work, is when Chris was speaking with some of the staff, he found out that some staff would tell him that if, for example, the Sunrise Clinical Manager login, if that page wasn't open up on the desktop, nurses would go about to a different computer, to find a computer where that was open so that they could log into the computer. Meanwhile, if that is not up on the desktop screen, all that a nurse has to do is click the computer that's circled in red there, and that will bring the login screen up. So that's one example of how we can improve upon helping nurses troubleshoot our current computer system. Further to that, and this is all very anecdotal data that we gathered, so I'm not saying that this is 100% accurate, but more or less just to bring awareness to our current state. Nurses would rate themselves anywhere between 2 to 5 on a scale of 10 if we were to ask them, with 0 being I do not feel comfortable using a computer, and 10 I feel very comfortable using a computer. So it's interesting when it comes from a nurse's perspective that they are recognizing some of their own inadequacies with working within a computer. And then finally, just reiterating once again that we do know that our current system does not require a nurse to have to know how to use a computer. So nurses have told us that they will swap tasks with others so that they don't have to enter their orders on the computer. They can have somebody else enter the orders, and then they'll go ahead and they'll do something for the other nurse. Further to that, we have unit coordinators. We're very blessed to have them, and they do a lot of our order entry for us. Some sites have, or units have them 24 hours a day. So that in and of itself helps decrease the responsibility on a nurse in our current state to have to learn how to enter orders within, or how to use the electronic system. So that being said, Diana Trifonova, who is the education lead over at CST, she has been working to create a computer literacy toolkit. And within that computer literacy toolkit, there's a computer literacy assessment. And that assessment tool I will hand out today at the end of the session. And that is something that I think that as leaders we can do for ourselves at this point to understand where our computer literacy sits. But further to that, that will be something that we will be eventually giving to the clinical and end user to use as well, to be able to assess their computer literacy and then to recognize where their knowledge gaps are and what they need to do moving forward. Within that toolkit, there are resources as well, so that nurses can go online and help support their learning and their competency within computer literacy. So to end off, I just reiterate the questions once again that we talked about at the beginning that are on that self-assessment tool. So the hope is that through this session, you were able just to gain a little bit of understanding about some of the informatics knowledge and some of the informatics competencies that we are hoping to help build here amongst our leaders. And that being said as well, if there's any opportunity that you think that, Brittany, can you come and meet with me and talk further about this or engage with our staff, like I'm more than happy to come and meet and help explain things as necessary. So please feel free to contact me if that would be of any support, and I'm happy to engage with you. So that's the end of today's presentation. If you have any questions, I'm happy to take them. If not,